Hello, everyone. I'm Shabana this side, and a warm welcome to all of you. I hope my voice is clear and audible to all of you. Can you say
Yeah.
yes or no?
Yes.
Yes. All right.
Yes.
Thank you. Okay. So thank you for joining this session, and I can see people are still joining. So I'll start this session with a small introduction to the MRCOG Part 3 exam. And then after that, we will practice two case scenarios from early pregnancy care module. One structured discussion and one simulated patient task. And also, I would like to congratulate all of you because if you are attending this session, it means you people have cleared your MRCOG Part 2, and that's a big achievement. Now, after clearing the Part 2, the question arises from where to start for the MRCOG Part 3 exam. So, well, that question is for the beginners and also for those who are retaking the exam. So it's always a good idea to start with the patient information leaflets, that is the pills. This will help in communication with patient. Those who are beginners, you can read the whole pill from first page to the last page. Those who are retaking the exam, like you can just read the management part. That's enough. What about the guidelines and talks? Yes, you will be reading the recommendation. That's important so that there is no gap in your applied clinical knowledge. And talks, yes, you will be going through the flow charts and the boxes. Practicing station with your study partner, that's important. And your study partner has to be very honest with you when you're practicing the station to give the honest feedback. What about the recalls? Very important. I mean, there are nearly 200 recalls which needs to be covered. And many are repeated recalls, many are important recalls. And we know that nearly 80% of the exams are recalls. Some are talk scenarios as well. So talks are also becoming very important. What about the courses and books? Well, we are always confused, isn't it? So you can take one or two online course, whichever you like, one or two face-to-face course just before your exam. Coming to the books, we have so many books. Lisa Joel and Oxford are the ones which I did during my exam. Lisa Joel, yes, you can read from first page to the last page. Very important and nice book. And there are 14 stations, and you will get a complete idea of the Part 3 exam. Oxford, it has very nice stations. I was able to cover 70 to 80% of Oxford. What about the other books? There are so many books. So you can do the labor ward, gynae ward stations, and new stations and selected scenarios from those books. See, no one can complete the whole, 4 to 5 books. And I don't think that it is also a very sensible idea. You can choose one or two books which you can complete. Rest of the books, just do the selected scenarios. What about the stations in exam? We know there are 14 stations covering the 14 modules. We know it is simulated patient task, structured discussion task, and the teaching task. Reading time is only 2 minutes. Performance time is only 10 minutes. So in the exam, you have to talk sense. You cannot tell everything in the exam. Total time is 168 minutes without any break. And everyone says that it's going to be the fastest time of your life. It really flies away very fast. How to perform well in exam? Be very calm, extremely calm in the exam. There will be stations with which you will be familiar. There will be surprise stations as well. There will be some difficult scenarios. And if it is difficult for you, it means it's going to be difficult for everyone. So please be calm, control your nerves, tell yourselves, I can do it. I have done my part too. I have read so much for this exam. I have worked so hard. I'm going to tackle any station. And if previous station you were not able to perform well, please don't be upset. Carry on with your next task. Just forget about the previous station. Keep calm and carry on. This really helps in the exam. Now, how to cover the whole syllabus? It's a daunting task. 14 modules, how we are going to cover those 14 modules. So, just a minute, I'll just mute. Someone is there. You can break these modules into small modules, large modules, what are your difficult topics, and the talk articles. Now, small modules are early pregnancy modules, self-fertility, sexual health, urogyne also. So you can finish them first. This will give you a sense of achievement. What about the large modules? Maternal medicine, labor and delivery, they are huge, huge modules. You can again cover just 1 or 2 stations daily. And you are your best judge. You know which is your weak topic, which is your weak subject, and what are your weaknesses and what are your strength. You know it better than anyone else. So for many of us, early pregnancy care and self-fertility, we know. So don't give too much time on these modules, particularly those who are retaking the exam. You give more time on those topics and scenarios which you find tough and which are difficult, and the new scenarios which are coming in the exam. And talk, daily read one topic, read the flowcharts and the boxes. And okay, this is the history template. We all know the history template. So outline is nearly same for all scenarios. You should know the template really well, but at the same time, modify it according to the scenario. You're not going to take all these history in all the scenarios. It has to be modified. I'll come to that, how we are going to modify that. Coming to the domains, okay, can anyone tell me what are the domains tested? Anyone of you can unmute and you can say. So these are the information gathering, communication with patients and relatives, communication with colleagues, patient safety, and applied clinical knowledge. So information gathering, this will include the history, examination, and investigation. So we all like this domain, isn't it? History taking, we all are very comfortable with. So again, you have to see whether it is focused to targeted history. If it is early pregnancy care module, then and patient is with bleeding, then of course it makes sense when you're asking about blood group or reservations for blood transfusion. But if an early pregnancy patient has come with nausea and vomiting, then it doesn't make sense if you're asking about the blood group and reservations for blood transfusion. You can skip that. Likewise, in A and E department, if patient has come with OHSS or post-op complications, you can skip asking about sexual health history, SSI, sexually shared infection, and the family history. And be an active listener. Role player is going to give you a lot of information in the information gathering. Try to listen to her very attentively. Be all ears. Being an active listener is very important. Communication with patients and relatives. Now, this also depends upon the scenario. If it is a breaking bad news scenario, then you have to be very calm and your attitude has to be very empathetic. If it is a happy station, normal station, then you will greet your role play with a smile on your face. If it is a teaching and structured discussion task, then likewise, you will be greeting your colleague with a smile. Also, examiner will see how you are carrying your station and how are you gathering and giving the information, checking the patient's understanding. Give the information in chunks, pause and ask her, am I clear so far? Do you have any questions? How are you engaging the patient and where you are able to make shared decision? Also, please don't use any medical jargons in simulated patient task. No technical terminology. Communication with colleagues, a very easy domain to pass. You will involve your multidisciplinary team. And if patient is diabetic, we know we have to involve diabetologist, diabetic nurse, dietitian, GP. Patient is a case of sickle cell disease, involve the sickle cell disease specialist or hematologist. So idea is that you will be involving the concerned medical specialist. What about the patient safety? It starts from the beginning of your station. When you're confirming the name and date of birth of the patient, when you're taking the history, ruling out or confirming allergy, confirming the blood group, asking about any reservations for blood transfusion, checking that the patient is Jehovah's Witness or not, that is patient safety. Offering examination with the patient's permission in the presence of chaperone. Then when you are telling about an investigation, discussing any report and confirming the patient's identity, that is patient safety. In the management part, stopping smoking, giving advice about stopping smoking, if she's taking any teratogenic drugs, asking her to stop that and converting it to more pregnancy-friendly medication, MDT care, in emergency cases, calling for help, that is also patient safety. Likewise, in any complicated scenario or in post-op complications, clinical governance points, these are patient safety points. Just remember the Ds. Debriefing, duty of candor, DATIX, that is your incident reporting. Then apply clinical knowledge. Just note down the words. It is applying your clinical knowledge. My dears, you all have the clinical knowledge. You all have cleared your part 2. The thing is that now you have to apply your clinical knowledge. That is mainly the management part. And for that, you have to revise the guidelines recommendations. When you are telling or explaining the patient about the management, offering her investigations, justify. When you are telling about management, ask the role player about the preferences, which type of management she prefers, and that will really make your life easy. You cannot, you in like when you're telling about the management, you just get about 5 minutes time. You cannot tell about expectant medical and surgical management in those 5 minutes. Like in ectopic pregnancy, there is expectant medical and surgical management. So just ask her, may I know your preferences? If she says medical and she says, I don't want surgical, you can just ask, may I know why you don't want to have surgical treatment? What's your concern behind that? And then tell her about the medical management. So that's going to save your time. What to do in 2 minutes outside the cubicle. There is already a YouTube video on that one, so I'm not going to elaborate it too much. But I would like to say that these are your precious 2 minutes. In the 1 minute, first minute, read the scenario really well. It has to be focused reading. In another 1 minute, try to make an outline. You can make flow charts or some bullet points, and you can just note down what you are going to do when you will go inside the cubicle and what is the station about. Never forget to introduce yourself. Confirm the name and age of the patient, in which clinic you are. If clinic is running late, please apologize. You have to see, is it simulated patient, structured discussion, teaching task? Is it a happy or sad task? What are the domains tested? Note them down in short forms. In 10 minutes, what is the task you have to perform? History taking, is it focused history, targeted history? Explaining condition, the management part, and of course, answering the role player's concerns. Now, answering the role player's concerns, it's very important. She will ask you many questions. She will interrupt you. And when you're answering her questions, it means that you are gaining marks, So allow her to speak as well. Just a minute, one moment, please. Okay. So we all say practice, practice, and practice. What does that mean? It doesn't mean that you have to practice like a parrot and you have to say everything in the guideline, whatever is written, you have to say everything. No. Why we say practice? Because this will help you to talk sense in the exam. This will help you to know how much information you should give to the role player in any particular scenario. This will also help you to overcome the communication and language barrier and practice with your study partner with a timer. So when you are practicing, one is going to be the role player, other one will be speaking. So one is talking, one is listening, and the one who is like an examiner, you will be noting down what your colleague is saying and give him or her a very honest feedback. In the end, you can discuss the missing parts, that what you missed and what should have been, what could have been done better. And there are some candidates who are a bit worried that my English is not good. I speak very simple English. Please don't worry at all. It is not a test of English language. If your English is simple, it's okay. No worries. Time management. The whole 10 minutes is not for you. Nearly 9 minutes or even 8 to 9 minutes is for you, and 1 to 2 minutes is for the role player. So this is just a rough estimate. The introduction and asking the concerns, aim and agenda, you should try to cover in half minute, or at least in 40 to 50 seconds. History and examination, this takes about 3 minutes. Explaining any condition, it takes about 1 minute. Management is 4 minutes. Closing station, if you are able to reach the end of the station, then you will get the chance to close the station. This also you have to keep very short. Do it in half minute. So what you people need to do now, stay focused and get it done. And for that, of course, you will be needing help from your study partner. It's a very long journey. You cannot do it alone. So try to sit with your partner and at least twice or thrice a week and practice initially 2 stations. Start to increase, make it up to 3 stations and 4 stations initially. In the last 1 month, make it nearly like 7 stations. Last 2 weeks, make it about 14 stations a day. So keep yourself motivated. All right. So this is all about the introduction. After that, we are going to practice the stations. So anyone has any questions so far? And who would like to do the station? There is one structured discussion task from the early pregnancy module, and there is one simulated patient task. Who would like?
May I do?
This, your name, please? Yes?
Husniara.
Yes, Dr. Husniara, please. One moment. I'll fix the timer. I'll change the slide. All right. So, all right. This one is for you. When you're ready, I'll start the 2 minutes. And relax, my dear. Please relax. Okay? Please be very calm. Don't worry at all. So your 2 minutes have started. Yes, my dear, start please.
Hello, I am Sneha. I have read the scenario. I am ready for discussion.
All right. So the scenario is here, and my first question is, can you summarize the case for me?
The lady comes with recurrent pregnancy loss. Her first three miscarriages was first trimester miscarriage, and her fourth pregnancy, it was second trimester miscarriage at 16 weeks. And it was spontaneous rupture of the membrane and followed by painless cervical dilatation and expulsion her pregnancy. Her ultrasound shows fundal dictation with partial septum in uterus, and there was a small subserous fibroid measuring 2 into 2 centimeter. For assessments, needs detailed history of her examination in presence of chevron with her permission and of her relevant investigation. Recommendation according to POJ.
Yes, okay. So can you discuss the important points in the history?
I would like, from history, I would like to ask her details about her pregnancy loss and which gestation her pregnancy loss was occurred, whether those were living or missed miscarriage, whether she taken any treatment for these, any investigation, where those miscarriages were in same partner or not. Then ask regarding her any like her menstrual history, whether regular or irregular, any problem during menstruation like pain, bleeding, what about her cervical smear, updated or not. Ask regarding her medical history, any medical problem like diabetes or any endocrine disorder, or any blood bleeding disorder, and ask regarding allergy, her BMI, her blood group. If blood group negative, that case I will ask whether she received NTD or not. And ask regarding her any surgery, any operation done in cervix or uterus, and family history regarding family history of any bleeding disorder or any birth defect. Ask regarding her partner history, about her partner is this partner's smoking habit, and also ask regarding her habit, whether she is a smoker, any recreational drug, what about the coffee intake, and whether and ask regarding her support and her assess her mental status. Then I would like to examine her in presence of Shifro with her permission. Ask, check her pulse, blood pressure, temperature, and her abdomen, check any mass, any tenderness, and per-vaginal examination, check any sign of infection. And then I would.
Okay. Okay.
Yeah.
What investigations will you offer her and why? Justify.
As a patient having recurrent pregnancy loss, I would like to offer her antiphospholipid antibody. Because it causes 15% cause of recurrent pregnancy loss. If positive, again, it is done after 12 weeks. If positive, that is patient having antiphospholipid antibody, that is offer her lupus anticoagulant and anticardiac antibody. Then I will offer her thrombophilia, estradiol factor 5 leading mutation, factor 2 prothrombin gene mutation, protein C, and protein S deficiency. If her symptoms suggest In that case, I will offer her diabetes screening, serum prolactin level, and thyroid function test. As patient having the 3 recurrent pregnancy loss, I would like to ask whether any that is histopathology done, product of conception or not. If tissue not available, that means I will offer her parental anytime. If patient, as she has ultrasound shows that fungal depression and partial septum, I would like to offer her confirmation of the diagnosis like laparoscopy, hysteroscopy, and infection screening, anti-sperm DNA not routinely recommended.
All right. Anything else you want to add in investigations? I think you have covered all. All right. So discuss the treatment options available for patients with recurrent miscarriage and second trimester miscarriage.
In this case, a patient having recurrent pregnancy loss, patient should be managed dedicated recurrent pregnancy clinic or dedicated early pregnancy assessment clinic. And patient may require patient need treatment of multidisciplinary team. If patient having antiphospholipid antibody, in that case she will be treated with low dose aspirin and low molecular heparin as soon as pregnancy diagnosed, and continuing up to 34 weeks of pregnancy. It is the only it is causes 15% of recurrent miscarriage, and it is treatable condition. If patient having hereditary thrombophilia, that case low molecular heparin should be considered. If a patient having abnormal thyroid function test, that is if mild, if antithyroid antibody positive, but TS is thyroid stimulating hormone normal, no thyroxine is recommended. But in case of moderate hypothyroidism, that case thyroxine should be offered. As if patient having abnormality of the karyotype, that case patient will refer to genetist, and her option whether either she trying to natural conception or PM plantation genetic diagnosis or donor or take it donor eggs. As it is evidence suggests a patient having partial septum uterus, evidence suggested that any corrective surgery of the uterus not improve the pregnancy outcome. Other than it may cause pregnancy complication. As patient having history of second trimester miscarriage at 16 weeks, that is, I would like to offer her serial surveillance of cervical length from 14 weeks onwards. If cervical length less than 25 millimeter before 24 weeks, that case ultrasound indicated surface should be occurred. If no cause is found, that is supportive care, improve the live birth rate near about 70% case. The routine corticosteroid or immunoglobulin not recommended. This patient needs supportive care. I would like to offer her counselor support. Thank you. In this way, I will manage the case.
Yes, well done. And you finished on time. Just few seconds. And I must say you have really done the station well. Thank you, Dr. Husniara.
Yes.
All right. So this structured discussion task, this is also very important and repeated recall. And now there's a new guideline on recurrent miscarriage, and all of you should go through that. There are a few changes, and which Dr. Husniara covered very nicely, I must say. So like you summarized the case very well. You started with the situation, background, assessment, and recommendations after taking history, offering relevant investigations, examinations. So well done. Important points in the history, yes, you covered the main important points in history, like you asked in details about the miscarriages and like the gynae history, menstrual history, cervical screening, medical history. Medical history, important history will be about the thyroid dysfunction, diabetes. Other history was complete. You inquired about the partner as well. That's important. And history, and then you offered examination as well. Then investigations, very good. You covered like we have to investigate mainly the most important cause will be the antiphospholipid syndrome. That is your acquired thrombophilia, the lupus anticoagulant and anticardiolipin antibodies, and then also inherited thrombophilias. Then you told about the cytogenetic analysis, the karyotyping. And if that is positive, then parental karyotyping. Parental karyotyping, and like if that is there, then we will refer the patient to the geneticist. Anyway, that will come in the management part. And since ultrasound showed the partial septum and all, so we need to confirm this finding by other imaging, like hysteroscopy, you told, laparoscopy, and if needed, we can go for MRI. So you covered nearly all the investigations. Well done. Then treatment options. Yes, we need to see the patient and the partner together in the dedicated recurrent miscarriage or early pregnancy assessment unit. And treatment will be according to the cause, which you said. You told about the antiphospholipid syndrome and the treatment, like low molecular weight heparin and aspirin. And if parental karyotype is positive, refer to the clinical geneticist. And if thyroid dysfunction is there, then again, we have to see patient is euthyroid or not, and or whether there is subclinical hypothyroidism. Because if patient is euthyroid and there is thyroid peroxidase antibodies, so in those cases, thyroxine is not recommended. But if patient has subclinical hypothyroidism and TSH is about more than 4, then we will be offering the patient thyroxine. Regarding the management, there is no evidence that surgical management of septum, that is septoplasty, is going to help the patient. And since this patient also had second trimester miscarriage, so you told about the transvaginal scan and for the surveillance of the cervical length. So well done. And yes, one important point you said that if it is unexplained recurrent miscarriage, we're not going to offer any empirical treatment.
Yeah.
Yes. So like from my side, you will, all these domains you have cleared very nicely. It's like a pass station. Well done. Okay, welcome. So let's have a look at this answer. So you will start with your introduction. And this is going to be your communication with colleague, that is the examiner. Then how you're going to summarize the case. This is a case of a woman with recurrent miscarriage. And summarization is, we know situation, background, assessment, and recommendation. So this is your situation. What is the background? She is 36 years old. She had first 3 miscarriages in first trimester, 1 miscarriage in second trimester, following spontaneous rupture of membrane and painless cervical dilatation. What is the assessment? 3D ultrasound was done, and the report shows that there is fundal depression and partial septum in the uterus. So what's going to be my recommendation? I will take the detailed history, offer the patient examination and relevant investigation, and discuss my management plan. Second question was discuss the important points in history. So this is your information gathering. I would like to know the details and history of each miscarriage, at what gestational age they occurred, whether it was missed miscarriage or living baby, any ultrasound was done before the miscarriage, how were the miscarriages managed, whether treated medically or surgically, any investigation was done or not, any treatment was given or not. Then other history we will complete, but still it is going to be very relevant histories. The gynae history is important. When was the patient's last menstrual period, whether she's taking any contraception, she's updated with the cervical screening, when was the last result and how is the result. Any STI in the past? What about her future fertility plans? Medical history, inquire about the medical condition. So whether she's having uncontrolled diabetes or thyroid dysfunction, she's on any medication, and whether she's taking folic acid, if she's planning pregnancy, any allergy, whether she's updated with COVID vaccine. Surgical history is important. Any surgery on her cervix, latest procedure, or any surgery on uterus. Occupational history, then inquire about the partner and support to rule out domestic violence. Partner's age is important. Family history of thrombophilia, social habits, smoking, drinking alcohol, any recreational drug or caffeine intake. Mental health history, whether she's having low mood or depression. What about the blood group? If rhesus negative, whether she received anti-D or not. What about her BMI? Because if the BMI is in the normal range, less risk of miscarriage. Then what investigations will you offer and why? So when you're telling about the investigations, always justify. As this patient had recurrent miscarriage, so I would like to offer test for acquired thrombophilia, that is for antiphospholipid syndrome, check for antiphospholipid antibodies, lupus anticoagulant, and anticardiolipin antibodies. How we diagnose APS? It is recommended that the woman should have at least 2 positive tests at least 12 weeks apart. And it is not done in the pregnancy, after the pregnancy. And at least 6 weeks post miscarriage. So if the women had miscarried, we need to wait for at least 6 weeks. Then we are going to offer tests for antiphospholipid syndrome. She had history of second trimester miscarriage, so we will be offering the test for inherited thrombophilia. These are mainly 3 thrombophilia which we have to look for: factor V Leiden, factor 2 prothrombin gene mutation, and protein S deficiency. Prior to testing for thrombophilia, we need to counsel the women regarding the implications for themselves and family members of a positive or negative result. Result need to be interpreted by clinicians with specific expertise. Second important investigation is cytogenetic analysis of the products of conception. So pregnancy tissue needs to be sent for cytogenetic analysis. If any unbalanced structural chromosomal abnormality is found, and parental blood karyotyping is done. Now, this point is also important, that if cytogenetic analysis of pregnancy tissue is unsuccessful, or there is no pregnancy tissue available, then we are going to do parental karyotyping directly. If there is abnormal parental karyotype, we will refer the patient to clinical geneticist. Now, this patient had 3D ultrasound scan done, which showed uterine anomalies. So we will be offering further investigations to confirm the diagnosis, that is hysteroscopy, laparoscopy, or MRI. Also check thyroid dysfunction by checking the thyroid function tests and look for thyroid peroxidase antibodies. And what investigations we will not offer, that is also good if you will mention in the exam. We will not be offering immunological screening, no infection screening, no sperm DNA testing routinely. Okay, last question was you have to discuss the treatment options available for the patients with recurrent miscarriage and second trimester miscarriage. So keeping this patient in mind also, you can tell that ideally the couple be seen in a dedicated recurrent miscarriage clinic or dedicated early pregnancy assessment unit. Lifestyle modification is important. BMI should be in the normal range. We will offer smoking cessation if patient is smoking. Limit alcohol consumption. Caffeine intake should be less than 200 milligram per day. Further treatment will depend upon the cause of recurrent miscarriage and second trimester miscarriage. So if antiphospholipid syndrome is diagnosed, we will be offering the patient low-dose aspirin and heparin, starting from a positive pregnancy test until 34 weeks of pregnancy to prevent further miscarriage. Now, advantages of heparin is that it does not cross placenta, there is no risk of fetal hemorrhage or teratogenicity. And unfractionated heparin versus low molecular weight heparin. So with unfractionated heparin, there is more risk of maternal complications. There is more risk of bleeding, hypersensitivity reactions, and heparin-induced thrombocytopenia, more risk of osteopenia and vertebral fractures as compared to low molecular weight heparin. If there is inherited thrombophilia, only then we can consider thromboprophylaxis, particularly if there are risk factors for maternal thrombosis and evidence of placental thrombosis. So in inherited thrombophilia, we are not going to give low molecular weight heparin routinely. There are certain criteria. If there is abnormal parental karyotype, then we know we will be referring the patient to clinical geneticist, and options for the couple will be they can attempt further natural conception or pre-implantation genetic testing, structural rearrangement can be offered, or gamete donation. Now we have to tell the patient that these treatments, they carry significant cost and risk. What about uterine septum and other congenital uterine anomalies? No evidence that hysteroscopic uterine septum resection improves reproductive outcome. In fact, with the surgery, there can be some complications in future pregnancy. Patient had history of second trimester miscarriage, so of course, we will be offering her the transvaginal scan for the cervical length surveillance from 14 to 24 weeks. If cervical length is 25 millimeter or less, less than 24 weeks, then offer the ultrasound indicator cerclage, and we are going to remove at 36 to 37 weeks. Coming to the endocrine factors, if patient is euthyroid and thyroid peroxidase antibodies there, we will not offer thyroxine supplementation. But if the patient has moderate subclinical hypothyroidism, TSH is more than 4, offer thyroxine. If TSH is more than 2.5 and only mild subclinical hypothyroidism, thyroxine is not recommended. What about the progestogen supplementation? So if the patient had history of recurrent miscarriage and she had history of bleeding in early pregnancy, then we can offer the patient micronized vaginal progesterone, that is the cyclogest pessary, or suppository 400 milligram twice from the time of bleeding till 16 weeks. This is according to the PROMISE and PRISM trial. You can take these names in the exam. Treatment not recommended. No immunotherapy, that is no immunoglobulin and no corticosteroids. There is no evidence that they are helpful. How are you going to manage the unexplained miscarriage, recurrent miscarriage? If no cause is found, only supportive care is successful, and future pregnancy can occur in like 75%. Successful future pregnancy can occur in 75%. There is no role of any empirical therapy with the heparin or aspirin. And patient and a partner should always be seen in a dedicated recurrent miscarriage clinic, provide them with all the psychological support. So this is how you will manage the patient. Thank you. So well done, Dr. Hosniara. Thank you so much. And just for the structured discussion, we need to revise this recurrent miscarriage guideline. Okay. And there is no need to investigate, for serum prolactin and something you said. Only if the patient is symptomatic, then we can offer the prolactin. Otherwise, no need. Okay, that was a tough one. Structured discussion is sometimes a bit tough because you have to do all the talking. All right, so next is simulated patient task. Who would like to do that? It's a simple one. Repeated recall. Okay. Yes, may I know who is this?
I'm Shaista.
Yes, Shaista. I'll change the slide for you. Right. Take you 2 minutes, my dear. Just one slide. This one
Yes,
only.
ma'am.
Okay, okay. Yes, start, please.
Hi, I'm Dr. Shaista, one of the doctors in the antenatal clinic today. May I confirm your name and age, please?
Yes, I'm Sarah David, 28 years old.
How may I address you?
Call me Sarah.
Sarah, first of all, I apologize. You have been waiting for last 1 hour. I'm so sorry for that. We started our clinic a bit late. We are looking into the matter, so it would not be repeated again. So
All right.
shall I continue?
Yes, okay, all right.
So I came to know that you came in the morning in accident and emergency because of vomiting, and you are pregnant as well. So how is your vomiting now?
Yes, vomiting is okay. The nurse gave me the anti-sickness medication.
Mhm. So are you able to talk now?
Yes.
Mhm. I would like to ask you a few questions to know more about you, and after that, I will discuss the management options. Would that be okay?
Well, doctor, actually, I'm too much worried about my ultrasound scan. And can I know the report first?
Yeah, sure. No worries. I'm going to discuss your report. And after that, I will inquire about you for the better management option. So, Sarah, I can see you are alone today. Would you like someone to be with you?
No, it's okay. You can carry on.
Yeah, so Sarah, I have confirmed your name, age, and your NHS number on your report. This report belongs to you. According to this report, you are pregnant, but this is not a normal pregnancy. Let me explain you. Whenever the normal egg from the mom meets up with the sperm from the partner, in that case, there is a normal pregnancy. But what happened in your case? There is an empty egg. That's why when sperm met with the empty egg, in that case, there would not be normal pregnancy. We call this pregnancy molar pregnancy, and most probably this is complete molar pregnancy. This is an abnormal pregnancy, and we call this molar. Have you ever heard about that?
Oh my God. So this is not a normal pregnancy. So I'm not having a baby, doctor.
I'm so sorry to inform you. Yeah, this is not a normal pregnancy, and we have to end up this pregnancy.
I see. I was looking forward to have a baby, you know.
I understand your concern,
Yeah.
Sarah. You can have a baby. There is treatment options. After that, we will guide you and explain you further about your future pregnancy plans.
All right.
Are you with me?
Okay. Yes.
Otherwise, your other investigations like your blood group, this is A positive, and your pregnancy hormone, this is too high. So, can I ask you a few questions before going to further management options?
Yes. All right.
So, may I know this is your first pregnancy?
No, doctor. I had a miscarriage before. You know, this is my second pregnancy.
All right. Could you tell me more about your pregnancy?
Well, yes, everything was going on fine. And like my last period was 7 weeks ago. But you know, I just was having more of nausea and vomiting. So I came to the emergency today.
Yeah, you're very right. This is because of your high pregnancy hormone. This is the reason, most probably because of your high, because of excessive vomiting. This is one of the side effect of this pregnancy as well. So, do you have any tummy pain along with that or any bleeding down below?
No,
Any passage of vesicles like grape-like structures?
no,
Any chest pain?
no.
Mm-hmm. All right. And what about your water bursts opening up bowel? Are they okay?
Yes,
Okay. Otherwise, your periods are regular.
yes.
Okay, Sarah, could you tell me more about your first miscarriage? At how many weeks and what was the outcome and how
Yes,
it was treated?
that was also around 6 weeks, and it was spontaneous miscarriage.
All right. Okay, so this is this relation is your first relation or you had before as well?
No, I'm with David with the last 2 years, and
Mhm.
we like he's the only partner I have.
All right. And did you conceive naturally or with medicines?
It was a natural conception.
Okay. All right. And what about your cervical screening? Are you up to date with that?
Yes, yes, they are normal.
And I believe that was your planned pregnancy, right?
Yes,
All right. Do you follow your GP for any medical problems like thyroid or
no,
high blood pressure?
nothing at all.
And this time your blood pressure is normal?
Yes,
Mhm. Any surgery in your past?
no,
Are you allergic to anything?
no.
Do you smoke or drink alcohol, Sarah?
No, I stopped them completely when I got pregnant.
I really appreciate your efforts. Pardon me for asking recreational drugs
Never.
and your weight and height ratio.
24.6.
All right. And what do you do for a living?
I'm a teacher.
Any family history of concern?
No.
All right. And how is the support at home?
Yes, David is very supportive.
Good to know that. Have you ever felt down, depressed, or hopeless?
No, never.
All right. Thank you very much for the information. Would you like to add anything else?
No, doctor, I would like to know how you are going to manage this pregnancy now.
Yeah, sure. I'm going to explain you. I can see your blood group is A positive. Do you have any reservations related to blood transfusion?
No.
Your observations are with me. They are also your blood pressure, your pulse. They are already normal, and your temperature is also normal. Is it okay if I check you before discussion of management options?
Yeah, that's
To
fine.
see-
Mhm.
I would like to see if you have any pain or you have any mass in your tummy, and I will see the severity of the bleeding. And if you have any grape-like structures, I will let you know. Would that be okay?
All right.
So, Sarah, we have number of options. Like this is a not normal pregnancy. So we have to end up this pregnancy. For that, we have to admit you. So, are you agree to admit with us?
All right. Okay.
And there are a number of reasons for this condition. For example, if there is previous history of molar pregnancy, or if the pregnancy is by assisted conception, that is by treatment, these are the risk factors for molar pregnancy. So you will be managed by a team of doctors, including my consultant, scan doctor. We will involve the counselor, support groups, GP as well. So, Sarah, as this is not a normal pregnancy, so we have to end up for this. There is one procedure in which we will empty your womb. We call this procedure suction evacuation.
Okay.
If we are not doing suction evacuation, in that case, there would be risk of heavy bleeding, rupture of your womb, and it could be life-threatening bleeding. And sometimes even cancer of the womb in 15 out of 100 cases. Are you with me so far?
Okay. Yes.
So the suction evacuation would be done by my consultant because this is a risky procedure. In this case, the womb is very soft and as your blood group A positive, so we are going to arrange the blood for you. And once this is completed, after that, we will send the samples to laboratory for the confirmation of diagnosis. As I told you, it looks like complete, but we have to confirm by a laboratory test. And after the procedure, you will be registered in one of the registry centers. We have two centers, one in Dundee, one in Sheffield, and one in London. And you will be registered, which would be near to your house. And there would be follow-up by your pregnancy test.
You complete.
As I told you,
Yes, yes.
As there is a small risk of cancer in 15 out of 100 cases. So to exclude that risk, we have to monitor you by pregnancy test. Am I clear so far?
Yes, okay.
So we will do your pregnancy test every week. Yeah.
All right. And
do you have any questions?
I'm worried if this condition can come back again if I plan my next pregnancy.
Yeah, there is a small risk of recurrence as well. But if, for example, if we are giving treatment in this case, then we will check, we will do the ultrasound beforehand, or we will do the pregnancy test after your delivery for the confirmation of the condition. As there is a risk of 1 out of 80 cases after one molar pregnancy.
All right. Okay.
So there would be early booking in your next pregnancy.
Okay.
Okay. Meanwhile, after this procedure, you have to take the contraceptives. All contraceptives are safe apart from that coil, because there is a risk of bleeding after using coil. And moreover, there would be a proper follow-up. Every week we will do your pregnancy test, either in the blood or in the urine. And once it is normal, if it is normal within 2 months after your evacuation, then there would be follow-up 4 weekly with the pregnancy test till 6 months after evacuation. If it becomes normal after 2 months of evacuation, in that case, your follow-up would be for 6 months after normalization of your pregnancy test. Are you getting me, Sarah?
All right. Yes.
Do you have any questions?
No. So basically, this will be treated by the surgical evacuation, which you said.
Yeah, we will.
Any
This is the treatment
medication?
options.
Can you give me any medication for this condition?
Before termination of pregnancy, we will give some like softening substances, but not for a prolonged period. If there is a risk of heavy bleeding, in that case, we give one injection to reduce the risk of severe bleeding. Otherwise, there is no as such medical treatment for molar pregnancy.
Okay.
Absolute treatment is radiation, right?
All right. So I'm ready for the surgery. Okay.
Yeah, I'm going to admit you. I'm going to inform my consultant. This is the consent form as well. You have to sign, and you can discuss with your partner as well. And I'm going to inform the theater as well.
All
And
right.
these are information leaflets. You can go through them.
Okay.
I'm here to take care of you.
Okay.
Thank you, Sarah.
Thank you. Thank you. Thank you, Shaista. Well done. Your communication is, as always, good. So good try, good attempt. And information gathering was like more or less complete. Communication with patient was good. Applied clinical knowledge, yes, good. Patient safety, also, I think it's okay. See, only thing is that few things, my dear. It is not early, it is not antenatal clinic, isn't it, Shaista? You said
It's my mistake. After, yeah,
yes,
I realized it.
yes. And the good thing you did, you apologized because I was waiting for over an hour. Well done. And after that, since I wanted to know my result first, so you told me the result first and you saved your time. Well done. That is how you will go in the exam as well. If the role play wants to know the result first, tell her the result first. After that, you took the history. So in the history, like it was fine, but you could have skipped family history. There is no family history of molar pregnancy. It does not run in the family, isn't it? And
Yeah.
okay, then somewhere I examination part is given, so you can save time. Like examination,
Yes.
you did say that I can see that your observations are normal. And when I was saying that, tell me the management. So before then, you said I would like to examine you, my dear. You can save the time there because I saw the timer and it was already like you just had 2.5 minutes to discuss the management. That is why I told you that I would like to tell me the management. How are you going to manage this pregnancy? Because I wanted to
Right.
save the time. You understand what I mean to say?
Yes, ma'am.
Then you
Very
went
right, ma'am.
back
Yeah.
and you said, yes, I'll discuss with you about the management, but is it okay if I examine you? So this is what the role player does in the exam. They want you to move forward, don't go backwards because they want to save your time so that you finish the station on time. So that took your precious 1 minute, that examination part. And that you said you will be checking the bleeding. I said, I don't have any bleeding. Okay, my dear. So, and then you started telling me about the causes. it was not
Yeah.
needed here. Okay, Shaista? It was not needed here.
Yes, ma'am.
Yes, so that's
Right.
going to save you time. Then the management part was absolutely fine. The section evacuation, how you're going to do the procedure. Follow-up, it's a bit complicated for a patient like who has just heard this bad news. This is breaking bad news station. So keep it simple that we will be doing the follow-up, checking your pregnancy hormones. This will be checked at some regular intervals after the procedure, and I'll be giving you the patient information leaflet regarding the follow-up. Telling her about 2 months, 4 weeks interval, then 6 months will be a bit complicated for her. Okay. So,
Yes, ma'am.
and otherwise, you carried the station really well. This, I mean, the communication was very smooth, information gathering part, and everything was fine. I'm just telling you this so that you will be able to save time in the exam. Okay?
Yes, ma'am. You're very right. I unnecessarily I told these are the causes, although she didn't inquire.
Yes,
Patient didn't inquire. Yes.
because the 10 minutes, it is very fast. The role player will speak for 1 to 2 minutes. The management part, by the time you will come to the management part, you will be having only 4 minutes or 5 minutes maximum, and then you have to say so many things. Otherwise, well done, my dear. Good. Keep it up.
Thank you so much, ma'am.
Welcome. Okay, we can just have a look at the answer. So yes, introduction. You confirm the name and age of the patient, apologized, and because clinic was, I mean, I was waiting in the clinic, so you can just keep it simple. Sorry that you have to wait in the clinic. I will say that it doesn't happen again. Is it okay if I carry on with the consultation? Your aim was, I understand you're here to discuss your test results, or you can also say that I can see that your last period was 7 weeks ago and some blood test and scans were done, and you're here to discuss the test results. Am I right? Is there any other concerns? She will say, no, tell me about my results first. Tell the result first, confirm the name, age, and NHS number, which you did. Well done. That is patient safety. And this is about the breaking the bad news. So this is, you will tell in 2 steps, give her 1 warning shot. I have some serious concerns regarding your result. 2nd warning shot. I'm afraid I don't have good news for you. And you can ask in the beginning, would you like to have someone with you? Or you can ask that after breaking the bad news as well. And regarding the test, you will tell that the blood test was done and it shows that pregnancy test is positive, pregnancy hormone is quite high. The scan report shows that pregnancy did not develop properly. I'm sorry to inform you that there is no baby in the womb. There's only excessive growth of water after birth. We call it as molar pregnancy in medical terms. Have you heard about it? You can draw and explain that. See, let me explain to you with this drawing. This is the womb, the ovaries, and the tubes. Normally, what happens that sperm and egg meet in the tube and baby is formed, pregnancy is normal. But in molar pregnancy, the sperm with the genetic material meet an egg which is empty. So all the genetic material is from the father. This type of pregnancy is not normal. There is only after birth and no baby. Am I making sense? She will start crying, and maybe if she says that, doctor, I don't have any baby, then yes, you have to like tell her very empathetically, I'm sorry to be the bearer of this news. I can see how upset you are. Would you like to call someone to be with you? Let me know once you're comfortable. Is it okay if I carry on with our consultation? After that, you will tell her that I would like to ask you a few questions and then discuss the further management plan. Will that be okay? Then, history of presenting complaint. Can you tell me more about your condition? How about your bleeding, passage of clots, any tummy pain, and nausea and vomiting? So you can ask in the beginning or right now also that I can see that you were having nausea and vomiting. How is it now? Would you like to have some medications for that? How about your water work and bowel opening, which you did ask? Good. You asked about the pregnancy. Is it a planned one or spontaneous pregnancy? Have you, the OBS history, have you ever been pregnant before? If she says that I had a miscarriage, then just say sorry. I'm sorry to hear about that. And how was it managed? And how was your recovery? What about your future pregnancy plans? Tiny history, inquire about the periods. How are your periods? When was the last period? I can see from the notes that was 7 weeks ago. Are you updated with your cervical screening? Were you using any contraception? Sexual history after signposting, any history of sexually shared infection or abnormal vaginal discharge. Then the medical history, any medical condition for which you're following your GP. Are you on any medication? Did you take folic acid in this pregnancy? Any allergy? And any surgery on your tummy or down below? Family history you can skip. Occupational history, how about your partner and support? Social history, asking about smoking and alcohol, recreational drugs. Mental health history, whether you're feeling low or depressed. And blood group is given, it is A positive. So you can just say, just to confirm your blood group is A positive, any reservations for blood transfusion. Thanks for these informations. Would you like to add anything important? So if you miss something, she will tell you. Then coming to the management plan, you explained it really well. You can draw and explain that and tell her first that this type of pregnancy is managed by an operation. We call it as suction and evacuation. I will explain to you how we do it. This is the womb and neck of womb, and this a small tube will be inserted into your womb through the neck of womb, and pregnancy will be removed by suction, done after putting you to sleep, done by senior or my consultant, generally a safe procedure in expert hands. But like any procedure, there are some risks. There can be risk of pain, infection, bleeding, and you may need blood transfusion. There can be risk of injury to the neck of womb or womb itself. If this happens, we may need to do a keyhole surgery or an open surgery. So regarding the keyhole surgery, would you like me to tell about in details? If she says, I know about the keyhole surgery, then you don't have to say everything. This will again save you time. After this, pregnancy remains will be sent to lab for testing. Am I clear so far? Any questions? Always pause after giving informations, check her understanding. Regarding the follow-up, that is very important. You will be offered the follow-up to make sure that pregnancy cells have cleared from your womb, because if the cells remain in your womb, there is 1 in 7 chance that it may progress to a rare form of cancer. I really don't want to scare you, but I want to make you aware how important it is to have follow-up. So it is 1 in 7. And where will be the follow-up? So you will be registered in one of the specialized centers, London, Dundee, and Sheffield, whichever is near to you. Follow-up will be provided by the experts. The pregnancy hormones will be measured in blood and urine. And how it will be done? The center will provide you with a kit. It will be posted to your house for the urine test. The blood test will be done with the GP. What about the duration of follow-up? Now, this will depend upon when your pregnancy hormone levels become normal, and we will give you written information regarding the duration of follow-up. Because telling her about so many things, it will be a bit she will not be able to take in so many things, because you just gave her the news of molar pregnancy. What about the contraception? So you will be advised to use contraception and avoid any pregnancy until follow-up is complete. Why it is important? Because if you will get pregnant, then we will not be able to know whether rise in pregnancy hormone level is because of this molar pregnancy or new pregnancy. What about the future fertility and future pregnancy? So many women, about 99 in 100, will have a next normal pregnancy. Same type of pregnancy can occur in 1 in 100 women. This is in the new patient information leaflet. Just go through that. It is now 1 in 100 women, they can have the same type of pregnancy. When you get pregnant next time, you have to see your GP for an early scan to confirm that pregnancy is normal. Any questions so far? No. Okay, so you can just ask her, are you ready for the surgery? Yes, I'm ready for the surgery. So if you're ready for the surgery, I will also be giving you the consent form. You can sign it. and we'll give you the rich information leaflet about your condition. Before the procedure, we'll offer you the blood test to check your blood level and to see how your liver and kidney are working. I will also inform my consultant, anesthetist, operation theater, and the blood bank, and give you the support group numbers. Also, after surgery, if you have any pain, bleeding, any foul smelling vaginal discharge, report to us immediately. And for that, we will also be giving you the contact numbers. Any more questions? Would you like me to repeat anything? No, thank you. Okay. Anyway, Shaista, you have done it well. And I know this is like just practice sessions. So otherwise, keep it up, my dear.
Thank you so much.
Welcome. Any questions? So, like, I'll try to arrange a few more practice sessions. I mean, on the weekends, Friday, Saturday, or Sunday, any day. So, I hope people will join and they will get the chance to practice. Okay, all right. So, I will end the session and I'll share the recording. All right, my dears.
Thank you, ma'am.
Thank you for attending. Thank you so much.